uh, uh, please forgive me. I just need to make some light there. Um, sorry, I'm back. I think this one is going to create problems for us. As we can see, I just came back from theater now. But I don't think it's a train smash. I think academics can be done anytime, anyhow. I was doing a gynae oncology list, so that's the one that showed us flames. Billy, Dr. Magagula, we have a post for you. You must come and apply to be a subspecialist in gynae oncology. We've got a post that is open. We've
Thanks
got
for
a
the
post that is
invitation.
open.
That's noted. Thank you.
Okay. All right. So today we are going to try and have a marathon because I didn't know what to leave out and what to take in. We are going to have a marathon that looks into the prevention, early detection, and treatment for early stages of cervical cancer. The reason being that we know that in this day and age of modern technology, nobody was supposed to die from cervical cancer. Nobody at all. Unfortunately, embarrassingly so, it is still the case, whether it's in public or in private sector, people are still dying. We still see patients who come at advanced stage, even the private sector, which means that partly it's us, we're doing something, partly is the patient, partly is the system. So we are going to try and break down some of these things. As a declaration, I don't have any conflict of interest, and this is not a sponsored talk. And I'm available for talk that are non-funded, non-sponsored, as long as I'm informed in time. For starters, Dr. Magagula had already said that cancer of the cervix is it's a public problem.
Dr. Mbodi, two things. Sorry
Yes.
to interrupt. Yes, some people are struggling with their own network, so you don't have to keep the video on. And then secondly, if you can share the slides as well. I think you are already ongoing. Thanks.
Oh, let me, I thought I was sharing the slides.
Sorry about that, yeah.
The video, are you able to, on your side,
Okay, I'll help
can
you.
you mute
Yes.
me?
No, it's fine. Sure, I will help.
I thought I was supposed to have been sharing the slide.
Look for that green arrow somewhere. Share screen. Because I noticed that you were already talking to the slides. Thanks.
I've got a different screen there. Okay, there we go.
Yes, it's coming through. Yes. Okay.
All right. So I've said these whole things already. Let's start here. Dr. Magagula has already highlighted that this cervical cancer is a problem. It's a major public health burden, actually. That if you have to look at it case by case, you realize that governments spend a lot of millions on cervical cancer. The mortality and the incident has declined in developed countries because they've been upfront with prevention. However, with us, we still a problem. It is ranked fourth in 2018, or it was ranked fourth in 2018 from Global Cancer Statistics when it in regards to incidence and mortality. We know that the common cause is HPV, which causes more than 96% of those cases. And these viruses, we know that there are those that cause pre-malignant, non-malignant, and those that cause pre-malignant and subsequently malignant conversion, which we are going to go into them. But let's see how bad is this problem of cervical cancer. If you look at the incidence only, the darker the color that you see, the more the cases that are there. If you look at Africa, you see that the majority of the countries, we are at 17.5 and more with regards to the incidence per 100,000. And the countries that are not as dark as us, as in South Africa, we need not to celebrate them because those are the countries where the stats are not recorded, predominantly rural. We don't know how many women are dying. As opposed to America and most parts of the Europe, you can see that we're in trouble. When you look at the number of people that are dying from cervical cancer, again, the darker, the worse the problem. Look at Africa, you can see that the majority of the continent is in the darker place. 30.2% and more, 30.2 and more, which South Africa falls into. And like I said, I know that we are a low middle income country, but we were not supposed to be that bad in this current state. So we know that the epidemiology of HPV and cervical cancer is well known. According to Global Can, there was 530,000 new cases that were reported, which subsequently had about half of those patients will die in that year. All cervical cancers have been shown to have an oncogenic HPV DNA. At least 30 different subtypes are known to affect the genital mucosa and the anal mucosa now that there's a lot of anal sex that we're engaging in. The commonest that we know, 16, 18, 45, 31, 33, 45, 58, and more and 68 and more. You are going to see in the next slide that there's a variety of those subtypes that are there. However, we know that in Southern Africa and in South Africa, we've got different strains that are most common. More than 90%, some literature says 80, more than 90% of women who are sexually active will have HPV in their life. So, but we know that the majority of those will be able, their immune system, their Langerhans cells in the cervix are active enough, are strong enough to eradicate it when they're still in the stage of CRN1. We worry about close to 10%, 9 point something percent, that will have a persistence of this disease, which subsequently is likely going to be a malignancy if nothing has been done. According to the South African South African HPV Advisory Board, they said that cervix is the second commonest cancer among women, following the breast cancer. It has an incidence of 22.8 per 100,000, and there's been more than 5,000 women that are diagnosed annually, and more than half of those are dying because the majority of our patients are still presenting late, where we can do almost nothing. Women who are HIV infected are at an increase of having HPV infection, and subsequently their immune system is also altered because of HPV. And those are the ones that have the majority of the malignancies that are HPV related. So this is extracted from WHO position paper. There's a paper that we did not publish, which was by me and Adam. It found that in our research, which was a prospective research, we found that 71% of patients, they stayed a walking distance from their clinics. This was a study done in Joburg around Soweto. A third of the study population knew what a pap smear was, and yet 52 had not done pap smear. So that was supposed to be not done, not. So even though they know, the majority had not done pap smear. But the mean period between the last pap smear and now was like 61 months, which is acceptable for those that had done pap smear. But when you look at their attitude and perception and knowledge, which subsequently results into what do they do when they realize there's a problem, which could be a cervical cancer, we found that 41% firstly decided to discuss with family and let it settle there until they came when they are late. 28% consulted the hospital first. So that on its own is a big portion. Once they see symptoms, which is most of the time irregular PV bleeding, which could be intermenstrual, contact or postcoital bleeding, or just an abnormal vaginal bleeding, or a postmenopausal bleeding. Majority, more than 25% consulted the hospital or the clinic. 13.5 consulted private general GPs. 11.6 consulted their traditional healer. With this slide in mind, look at the percentage. You can see that more than 45% of patients came to us as healthcare providers. We always blame and say people are going to traditional healers, they are going to faith healers and everybody else, but the majority are coming to us first. So it means that partly we are to blame, but we'll also find other factors that are putting patients or the community to blame. But first of all, let's go to the pathogenesis. This is the bug that has caused more than 95%. Some literature says 98. Some just say more than 90% of CSFX is HPV related. We know that HPV is relatively a very small virus, double-stranded, spherical with a capsid, and the capsid has two proteins that are structural, that are very typical, that plays an important role in its replication, the L1 and the L2. So all these are for structural build-up. The E1s are the ones that are used. E1 and E2 are used for infecting the pathogen or the patient in this case. So we know that it's non-enveloped DNA virus from that family. There's 40 out of 170 subtypes that infect the genital tract from where it starts and where it ends. The low risk ones are 6 and 11. So those who said they are the ones that are responsible is not true. 6 and 11 are responsible for the warts, and then which are the benign lesions. Whereas 16, 18, 31, 33, 45, and the rest of them are up to 99%, the ones that are involved in cervical cancer. When you look into the life cycle of this HPV, you find that, so the issue is, as compared to what is happening on the basal stem or on your basement membrane, parabasal membrane, and the squamous layer, and then what happens to the mature squamous layer, you realize that this is just a process which is a cascade. You have an infection of the basal by E1 and E2, and then when that happens, you have an upward projection. If you are looking into the cell in that manner, you have a episomal viral DNA in the cells in the nucleus, and you can see the growth, the pattern, and the takeover on the genetic makeup. Still, you have an influence of E1 and E2, plus E6 and E7 have joined the way. So, which makes it more at risk of being infectious. And then furthermore, you have viral DNA replication. Now it's using predominantly E6 and E7. These are proteins that are there. After that, then you have shedding off of these viruses because replication has happened. Shedding off, waiting for the next host. So how does it enter the cells? It enters the epithelial cells through the microfissures that are there. So each sexual intercourse is traumatic. There are cracks or microfissures that are happening in the genital tract, including on the skin of the penis. Each intercourse, whether there was a condom or not, there would be a skin to mucosa contact that happens. People who use condoms will tell you that when you do use a condom, well, in the beginning, it's on the waist. You feel like you can even tie the belt around it. But when you are done, you'll find it at the glands. So it means that the majority of the time when you are having intercourse, the skin of the penis has direct contact into the mucosa. With those microfissures that are there, you have that shedding off of the virus, and then they come and enter through that microfissures. So then what happens subsequently becomes a cascade. So it's either these cells or these HPV viruses, it's either they become transient and cleared by a host immunity if no disease has formed yet. You just infected, but no disease. So if the immune system is good, again, Langerhans cells on the cervix, we're talking about cervix when you say immune system here. If it's good, then the host will be able to clear it completely. If it's not good, then they'll be persistent. You have pre-malignant conditions, which are CIN lesions, CIN 2 and 3 in this specific area. So, but most of it starts as CIN1. And then you have a chronic HPV infection, and then you have a lot of viral production, shedding production. It becomes a cascade in the same cervix. And then the cells, even though they are supposed to be defending you, or the immune system is supposed to be defending, it gets tired of defending. So there must be a way of screening for cervical cancer. I know that the majority of us, when we were in university, we knew that we're supposed to do it every 10 years, from 30, 40, 50, because we are assuming that beyond that, after 60, our lifespan was less. People were more likely going to die at around 60 years of age. So if you do it 30, 40, and 50, it makes sense if the pap smear was normal. However, that's old school, and majority of it was based, was a thumb suck based on budgets that were there. There was no science, real science behind it. But before you take into consideration that you want to screen, so you need to know that the goal of any prevention program is to reduce the morbidity and mortality. If you are going to screen and it doesn't do that, it's useless. So currently that 30, 40, 50, it does not reduce the morbidity. We are seeing a lot of patients that are coming with advanced disease. That's the morbidity. And like we have seen, more than 50% will demise. So somehow it's not working, this screening program. So it must also be able to identify leading to destruction of CIN lesions that are there, because we don't want them to progress into malignancy. So if these are in young women, we know that they might regress. Anybody who is less than 35, we know that this might regress, and we're not supposed to bother them. Hence, the program currently says you must start at 35 years of age. So our screening basically, classically, was relying on a pap smear or Papa-nuclei cytology testing, which in the majority of times was followed by colposcopy. WHO has a criteria for you to decide if this is a screening tool or not. So a screening tool, for it to qualify the definition of screening tool, it must meet all these 10 variables. I'm not going to go through them because those are what we have been exposed through as undergrad. But before you ask yourself if this is screening or not, if you want, you need to apply it on ovarian cancer, you can look for that. So traditionally, cytology, we've been using a slide, and now there's a liquid-based cytology that is we do. Cytology, what it does is it interprets all the mutations that are there on the cells, all the methylation, and other genetic modification that could have been there secondary to HPV. It looks into the nuclear and cytoplasmic appearance of these cells. They then calculate the ratio. And when they report it, they base their reporting on the Bethesda classification system, which was the famous one was in 1998. It has been since revised and updated in 2011. So there will be squamous changes that are related to HPV, which all of the time they are going to be called intraepithelial lesions. Whereas those that are intermediate lesions are called atypical squamous cells. When I tell students, I always tell them that the atypical squamous cell, or so-called ASCAS or ASCAS-H, which means atypical squamous cells, but you cannot rule out high-grade squamous intraepithelial lesion, is that the cytologist, because not a pathologist now, a cytologist is sitting on the fence saying, I see this cell is not normal, but it does not really fit into the squamous changes. I'll call it intermediate and say you must interpret with caution. So this is how the reporting on the Bethesda looks like. So if you find the report and it does not follow this sequence, it is supposed to be, it's expected that it will confuse you. So you want that everything to be reported in that way. But it's not uncommon to find that its reporting doesn't follow the structure, even though the cytologists have this framework that they can use. In the near future, which is supposed to be starting now, I know that in some private sector, people have already started. The screening program is likely to change in the near future. So there's three phases that are either going to be done. Either we say once in a lifetime, a person from 35 to 65, you do HPV testing. If you are negative, we repeat HPV on the basis of costing recommended, once again, 5 years or after 10 years. If it's negative, then you say leave that person alone, and that's where the lifetime would be. If it's positive, you are likely going to say, let's triage it to cytology, because here the screening is HPV. Let's triage it to cytology. If cytology is negative, we say, no, we'll repeat HPV testing after a year. Remember that HPV test tells you about the pathogen, not the disease. It tells you that the offending organism is there, which means that because 99% and more are caused by HPV, if HPV is not there, we do not expect the majority of malignancies to be there. or as opposed to the other ones that could be an adeno, or that 1% that is secondary to other factors, which might, if we have time, could also be a little bit of genetic component there, especially on people who are old now, where mothers were exposed to agents that are supposed to cause that genetic change or intrauterine change. So if cytology says there's an ASCAS or a low grade or high grade, then these patients go to for alerts as a treatment. So remember, we screened with HPV. If it's positive, we say cytology. If cytology is negative, we say we'll repeat later, because cytology tells you that there's abnormal cells. In other words, the pathogen that we identified as HPV has caused disease. If it's negative, it means it has not caused diseases there. That's why we can repeat after a year. If you look into flow diagram B, which says you can do HPV alone or in combination, especially on those that are 30 years and more, and then it gives you the opportunity to increase the interval. So at 35 to 65, which is the cutoff where you are going to stop doing the test, you do HPV and cytology. That flow diagram B is the commonest that is used in the laboratory now. So when you do cytology, you also tick that you want HPV. If HPV is negative and cytology is negative, then you are going to say this patient is safe. We know that within the 10 years period, the likelihood of this patient having abnormal cells that subsequently become cancerous is very slim. Hence, you can say that if you have seen this patient now, you can even extend and say, I'll screen you in 10 years. So flow diagram B is supposed to be very cost effective, especially in the population that has good follow-up. So whereas if it's the patient is HPV positive, but the cytology is negative, they say that you can repeat cytology after a year. And then if it's positive, then you do cytology again, and you might have to treat them with a lead. Whereas any patient who's positive, and whether cytology is negative or not, you are going to treat them with a lead. So you'll find that this is from the European Society. You find that the South African HPV Advisory Board has their own recommendation, and they've recommended that to the National Department of Health. I know that they've got the document. Perhaps after this pandemic, they'll have enough money so that we can implement this program that also tests with HPV. Right now, most of the facilities in government have moved to do liquid-based cytology, which is good for doing the HPV testing. Whereas diagram C says you are using cytology. If it's high grade or more, so and then you assess, including check the patient to colposcopy, the more here being what that you are suspecting that there could be a malignancy, send to colposcopy. If it's an ASCAS or AGAS, which is like all there on the border there, you do an HPV testing. If it's negative, then you don't treat, you leave that patient, you'll see them after a year. But if it's AGAS, because it's an intermediate AGAS, ASCAS, then it's HPV positive, then you need to consider that patient for follow-up so that you can treat them. So right now, what do? If you want to be safe, on the safe side, you go and see what the HPV, South African HPV Advisory Board, or what SASGO and SASOG have on their website as a recommendation, as a recommended flow diagram. So it's going to be intermarrying one of those things that we're talking about. So we know that the pap smear actually detects 60 to 90% within 3 years of its introduction. So it does not tell you that these patients don't have and completely, and it won't pick up all of them. Hence, it's called a screening tool, not a diagnosing. Even though you get that there's malignant cell, you still continue and triage after the pap smear, because pap smear is screening. This is the recommendation that we knew. I'm not going to talk about it again. So we're still doing the cytology-based screening. It has worked in European countries, but with us, it has not worked. But there are other countries like Chile who are supposed to be low middle income countries where it is working. So which means that the problem is truly with us. Some of the reasons they're not working is because there's a lack of political will. And the problem with coverage and the targeted age that we had, and the problem with follow-up, especially even in HIV positive women, even at HIV clinics, we are seeing patients who did not have pap smear at all. But what are the biggest challenges? What we are doing now is an opportunistic screening. We still wait for a woman to come and say, when was the last pap smear? We do not have women who walk in, or we do not actively have pap smear clinics where we know that they'll be fully packed. So we are still doing opportunistic screening. There's still a lot of lack of knowledge regarding cervical cancer in our population. Believe you me, even on patients who are educated. Screening at clinics is not prioritized. We are still on chasing the diseases that are there instead of being a preventive model that is used by other countries like Cuba. If we are doing that, screening for cervical cancer would have been prioritized. So there's also a lack of follow-up, lack of treatment facilities. Once you diagnose it, then what? If you ask around how many centers do colposcopy and LEDs, very few centers. So sometimes people get high grade and they end up progressing with the diagnosis. Nothing is done. We also don't have adequate training. In public sector, we have a lot of turnover where people resign. They are not replaced by people who are trained, or the training is not there. So now there's a new kid on the block, which is an HPV, which there's a lot of different subtests that are there, ranging from ECOBAS, Vista, Roche. So some of them have a panel that tests for multiple of those, including 16, 18, 31, 33, 45, and the so-called type A, which includes the other one that are high risk. So the prevailing thought is it's supposed to have an excellent sensitivity. So it's supposed to, an HPV test, if it's a high risk HPV negative, which means let's take the 16, 18, 31, 33, 34, 33, 45. If it's negative, it's highly unlikely that this patient will develop cancer in 8 to 10 years. And hence, you had that period where you can say, if you are a good follow-up patient, I can see you in 10 years. But has a poor specificity, which means that those same high risk HPV, if it's positive, it detects the infection, remember, not the disease. So it's not specific. Saying that you are positive, it just means that you have the pathogen, but not the disease. And the cancer is the disease. The high grade lesions are the disease. So, and we know that in the majority of women, it will regress. We just have that 9 point something percent that will persist and become a problem or a burden. So if patients are HPV positive, they need to be triaged, like we said. Colposcopy, you can do it in expensive. It's expensive in private because people do it in the theater. They don't do it in the rooms because of cost issues, medical legal issues. In public, colposcopies are overbooked. So the patient might wait and even become malignant. Or we missed a small invasion, a small foci of invasion that we could have treated. The cytology, yes, is a good thing for us who are the low middle income countries and wealthier nations. They've been using them and it's working. And VIA, if we don't have resources, the visual inspection after application of acetic acid serves very well. So don't forget that HPV test, um, just like any other test, can be operator dependent. Even though this is going to be done by a machine, developed countries like New Zealand and US and UK, Australia have been having studies and they are way advanced. So we don't know that if we do HPV test in our sector, will it work? Will a self-collection work? Because in UK, they can say the Department of Health or their NHS can send you a package where you do your self HPV test collection. You send it back to government by a post. In our setting, will it work? Our posting system doesn't work as effective. Again, we also have a large population. It will pose a challenge in the Muslim women because culturally and religiously, they wouldn't be allowed to do such. So how will you then prevent? We know we can divide this into primary, secondary, and tertiary. We know safe sex is a good, but like I said, safe sex will not stop completely because the condom will not cover up to the edge, up to the top. it's not going to be possible. So how about if you stop smoking? Yes, because you are going to enhance, when you're talking about a woman here, those Langerhans cells in the cervix, the immune cells are going to be enhanced further. We know an HPV vaccine works, and there's a lot of debate about male partner circumcision, but those who favor that say that, so if there's a foreskin there, it harbors the HPV, it encourages it to grow in big numbers, and it's always there to reinfect the partner. But we are not sure. So I'm saying we on our side as South Africans, because most of the studies that you'll see are done in Europe. Secondary prevention is your pap smear, and the HPV test is also a secondary, whether you're doing VIA and VILI. VIA is visual inspection under acetic acid, and then VILI is visual inspection after Lugol's iodine application. In Southern Africa, so in DRC, the commonest HPV subtype they have is 35 and 52. Sub-Saharan Africa as a whole, 16, 18, and 35 and 52. What do we have here in South Africa? In South Africa, there was a point where we saw an increased number of 33 and 58 in Durban, but HPV 16 was seen in such a smaller percentage. But there was a lot of 33 and 58. In Mozambique, they are seeing 51, 35, and 18. So you can see that it's a variety. It creates difficult when one has to think of a vaccine. However, when you look into this phylogenetic tree, you will realize that, so even though these subtypes are many, you've got these subtypes and you might be worried that we have 16 and 18 that are common, but I mentioned 33 and 35 and 31. You can see that they share the same genetic tree. If you are giving a vaccine to protect against 16, you'll protect against 31, 35, 52, 33, and 58. So if you give a vaccine for 18 and you'll be protecting against 45. So that's the advantage of the vaccine, because there's that overlap that is there. So we know that after screening, let's say from tomorrow government decide everybody's going to get a vaccine. We know that we're still going to need to screen patients, because we know that the Cervix and Gardasil, which are the vaccines that are available in the market, they prevent about 70% of cervical cancer. And we still have other problems, because there will be those people who were not vaccinated before, who by the time the vaccine came, it's too late, it won't be necessary. And there will be other lesions that are not cervical HPV associated, even though it's a small number. So there will still be a lot of HPV, a lot of screening, including cytology, that will still be needed. But they are concerned that in Southern Africa, in Sub-Saharan Africa, HPV might not work because of problem with malnutrition, HIV. So the immune system is already not so activated. It might not yield the same results as what is happening in Europe, but the only way we'll know is after checking. Unfortunately, we can only know after 2 or 10, 20 years or so if the vaccine is working. Because if you find a patient who is 29, who is 9 years old, we'll have to wait for them to be 35 before we check them, and we see that it worked. So unfortunately, by the time we realize it didn't work, we would have done the vaccine. However, you can be rest assured, because there's less side effects. That's why we are seeing that in public school, there's been a big uptake, up to more than 90% was targeted, but they got a 70% by the time we prepared this presentation. In private school, the uptake is not as good, because government is not funding, so people are supposed to go by. So the plan was to vaccinate both boys and girls. It makes sense. You cannot vaccinate one person, the victim, and you don't bring the other one who is likely going to bring the HPV with. So unfortunately, money is supposed to be, or the cost to the vaccine is likely going to be the bigger problem. So how do we then manage them? There are different ways. If these are pre-malignant, you can do local distraction with cauterization, just like you do with the warts. You can do cryotherapy, you can do laser, The first two are available in public hospitals, in most public hospitals, whereas the laser is available in some public hospitals, not all. But you can also excise the lesion completely, because the first one we are destroying without excising anything. You can excise it by doing a LETS and cold knife cone biopsy. LETS has an advantage that is a bedside procedure, does not need general anesthesia, it's localized, patient goes home. Whereas cold knife cone biopsy, you have to get a theater list. The patient might need to be admitted the day before, might be admitted a day after the op, because you want to check that there's no bleeding that is still happening. Or on patients who has completed the family who meet the criteria, you can do radical excision, not radical hysterectomy. We're just calling it radical excision because you have a cervical lesion, but you remove the whole womb. So if you have a CIN lesion, what do? You have done a pap smear, it says low grade or CIN1. These are the patients that if it's the first time, first ever, that's why you need to ask your patient. If it's the first time, you tell the patient that you are going to repeat this test in 6 months, they must come and see you. If it's a repeat, CIN1, it means this thing is persisting. Remember that CIN just means that HPV has been there. If it's persisting, it means the immune system is failing to get rid of it, it's starting to be a disease. Try these patients to colposcopy. Bear in mind that colposcopy is not equivalent to LETS. Colposcopy means look, magnify, decide if this is high grade or not. Do you need to worry or not? If it's CIN2, you try it straight to colposcopy. It needs to be excised or ablated in adults. CIN3, straight to colposcopy, excise or ablate. CIN2 and CIN3 are classified as high-grade squamous intraepithelial lesion or high-grade C, because it's not known how long it takes for you to progress from CIN2 to 3. It's also not known whether CIN2 can progress to malignancy before becoming CIN3. It's also not known when you see a person now, they're CIN2, even if we decide it takes 2 years, you don't know if this person is on 1 year, 11 months, and 3 weeks, which means next week they are 2 years. So that's why they classify them together, and the management is the same together. So ablation is very effective. But the problem is, if you are suspecting a malignancy, it does not give you a specimen. You will never confirm. You will just eradicate, destroy, and you might be destroying the CIN lesion that is there, which is superficial, whereas deep, then there's still this lesion that could be a malignant. So cryotherapy, most of us know how cryotherapy works. It's not advisable to use it on CIN3 lesions because the likelihood of having malignancy is very high. So this vaporizes for 5 to 7 millimeter deep. If there's a malignancy, it will have a depth more than that. So you are not going to be eradicating that. So hence, with CIN3, because the likelihoods are very high, rather don't do it if you have it. The LEDs itself, so it gives you an opportunity of taking the specimen for, it gives you both therapy and staging of the disease, or to look and identify. So therapy, because if you have followed, you have done the LEDs properly, you used your acetic acid to stain, followed by lugosiodine, you can be able to see the margins, and you excised on those margins. Please remember that the excision is targeting the transformation zone. If you are doing superficial excision, you have done nothing. So when you have done a LEDs, your specimen should look like the bottom right. So the one on the bottom right must look like that, and make sure that it's one specimen. And please use the cut function, not the coag, because the cut gives you a sharp directed electrocution, which comes out as a blade that cuts through, whereas a coag gives you the energy that goes sideways because it's meant to stop coagulation. So the pathologist will tell you, I don't know whether margins are free or not because you bend them beyond recognition, which does not help you. You don't know what to tell the patient. Did you cure the patient of the CIN? You don't know. So use cut, don't use coag. A cold knife cone biopsy, like I said, the problem is it needs you to have a GA, and you are not going to do it on patients who are less than 35. Fortunately, even the guidelines says don't do pap smear on patients who are not sexually active, patients who are less than 35, because the majority will have CIN1 and you'll panic unnecessary. You end up doing a cone. These patients are going to have recurrent miscarriages or preterm labor. If there's a malignancy, what do we then do? So there is a role. The reason I put this as well is because I know that there have been debates on whether people who are not gynae oncologists can do surgery for cancer patient. If your patient is a stage 1A, you can do. Anybody who knows how to do a hysterectomy safely can do, because you do what is called conservative surgery. You can even do a cold knife cone biopsy. Survival outcome is good. These patients, their chances of having lymph node involvement, lymphovascular space invasion is less than 1%. Hence, a simple hysterectomy can work. But you should have been told for real that this is a 1A1, so not a 1A2. For patients who have completed their family and the elderly, do the simple hysterectomy. Women who still want to preserve their fertility, you can do a cone knife cone biopsy. Patients who are 1A2, so they are treated by radical hysterectomy, most of them, plus a pelvic lymph node dissection. Up to 15% of these patients will present with an early disease and they might have positive nodes, up to 15 who are 1A2. Hence, the lymph node dissection is important. But on patients who still desire fertility who are young, you can do what is called a radical trachelectomy instead of doing a radical hysterectomy, plus lymph nodes. Yes, there's a role of doing sentinel if you know how to and you have resources, because a sentinel lymph node dissection gives you an opportunity to avoid doing radical lymphadenectomy, which has an increased morbidity. You identify a sentinel node, you send it for frozen section. The pathologists tell you within 30 minutes whether there's malignancy or not. If there's no malignancy, you stop doing anything. You don't continue with the nodes because they are free. So whereas there's a radical hysterectomy is indicated for anything above that, 1B1, 1B2. So we have seen that up to 24% on 1B2, and then up to 4% on 1A2. Historically, they've been done. So 72% of the time is on 1B1. So the reason here, this statistics that is here is based on the old FIGO staging. If it was new, we would have had the 1B3 there, which is there. So FIGO had a new stage in 2018. It's available in the free internet. If you just go FIGO 2018 Brazil cervical cancer staging, you'll get that document, which is like 8 to 9 pages. You'll get this table that is staging. So you will need it just as a reference so that when the pathologists say, this is what is happening, you are able to do. However, there's nothing that stops you from learning and practicing how to perfectly do staging so that you know which patients to refer, which patients you can do. You are referring because the patients that have cervical malignancy, they are likely to benefit on the first operation that is done. So if it's a more than 1A2 and more, you are likely going to say, I'm referring to a person who either is a gynae oncologist or has been doing them for a long time if they are not certificated, so that the outcome is way better compared to it being done by you if you don't have experience. But you can acquire the experience by assisting, by training informally, so which is not such a big issue, just that it's a scary procedure. And then I've seen that there's questions already that are there. But the take-home message is, we are not innocent as healthcare providers. At most of the time, even the gynaes, we don't ask our patients about pap smear. Even though we are trying to encourage that this is not opportunistic, we must ask. But we must also teach them that this is not supposed to be opportunistic. They must come to you every 3 years. I'm bringing up 3 years because the South African HPV Advisory Board is moving towards 3 years. From 35 years, every 3 years, it is normal. So if HPV negative, and then cytology is also normal. So we are likely going to do that. So the take-home message is, let's offer them, let's allow them to come, let's not be opportunistic, let's identify these lesions when it's still early. If you identify lesions when they are more, when they are early and they are more, and we run out of colposcopy clinic space, there's an NGO that is from the Bill Gates Foundation, which has donated into Mpumalanga, Limpopo, and Gauteng a lot of LEDs machines that are portable, can be used anywhere, that are battery operated, don't need electricity. So if you're in the rural area, you can even do the LEDs with those machines. So that's the perfect machine to do what is called VIA or VILI. Put acetic acid. If you see an aceto white, when you use what is called a RAIDS colposcopic index score, and it says to you, this is a high-grade lesion, you do a LED so that you can cure the patient. It also gives you an opportunity to do pathological diagnosis. The other thing is, we need to refer our patients early, whether they are operable or not, because early is not just about the early stage. Because even if it's at stage 2, there are patients who are stage 2 who are still having a good ECOG functional status. So they are still mobile, still doing well. Even the pain is not that much. And they still don't have renal functioning. These are the patients, when they get chemo radiation, they benefit a lot, and the cure rate is close to 90% on this patient. And they will be cured with less side effects from both chemo and radiation. So early identification, whether it's just a diagnosis, is a good thing. We need to do it. Thank you.
Thank you. Thank you very much, Dr. Mbodi. Yeah, that was quite informative. Dr. Magagula, are you there?
Yes, I am, Alice. I just got disconnected by my poor connection. But yeah, thank you so much, Dr. Mbodi. That was really very comprehensive. We've a lot of information that we've taken in. It was an excellent presentation. We do have quite a few questions that we need to go through. I get a sense that what we probably the only armamentarium that we have, in the fight against Cervix in South Africa, it's basically HPV vaccine as well as screening. But we know how badly our screening program has failed, as Dr. Mbodi has alluded to. It has succeeded in other countries, but in South Africa, it has failed dismally. I remember back a few years back when I was working for one of the NPOs that are supported by the Americans, where we used to do a lot of this cervical screening and treatment by colposcopy. When we looked at the NHLS data, and this is about 6-7 years ago, the quality of pap smears was very, very poor. So, they would actually get a pap smear that doesn't have the endocervical cells, so difficult to interpret. So as well as the coverage was very poor. I think the Western Cape was doing very, very well when it comes to coverage. I'm just wondering, Dr. Mbodi, how best can we adapt our screening in South Africa to try and improve, the outcomes? And I think Martha has just asked a question which sort of speaks to what I'm asking. Asking about HPV. She says, with the high prevalence of HPV in our country, do we have enough facilities to deal with all the HPV positive cases? It's probably a difficult question from a clinician's perspective, but I don't know. What are your thoughts around how best can we improve our screening, since we are trying with the HPV vaccine in the schools?
So I think I'll also answer some of the questions that are there. So
Yes.
So the biggest problem with us is that our screening, even from conception, it was never meant to be an active method. We were being opportunistic. We wait for patients to come, and then we ask them if they've done pap smear. We don't have preventive methods. And our clinics, which are supposed to be the first or the front line in prevention, they are bombarded with patients that they're supposed to treat. There was a trial of doing 1 million women pap smear to try and see if patients really don't come. Although they stopped it in the middle, but they realized that patients do come. The bigger problem that you get is the results. Even though now we have electronic systems that are there, we still have not good support. So that's why we had said we think there's no political will. We have seen what is happening with Corona now, that there's a lot of political will. Government is throwing all the resources from anywhere. If government can do that, I'm telling you, if we decide that at the clinic, there's a site that is just for HPV screening. If we tackle HPV, cervical cancer the same way we do it with HIV, we're going to win. When HIV was still a problem to us, we had spaces in clinic which are dedicated for HIV positive patients. Patients will go there, they will make sure we mobilize their treatment, their testing kits, the blood tests that are collected. We had an active program and we won. We had a lot of patients that were dying from HIV then. We won such that it became so acceptable and it's freely available everywhere. You can test everywhere, you can get treatment. We can do the same thing. If you copy and paste what is doing in HIV, the treatment being the vaccine, we can win. However, answering some of these questions that are there, if the patient has done a hysterectomy, it depends on what the hysterectomy has been done for. Let's start with the West. Hysterectomy was done for cervical cancer. Pap smear is a screening tool, is to see a cancer before it becomes cancer. If you have done a hysterectomy, you have achieved that already, you had a cancer. You do not need a pap smear. When you come for review, be it annual or every 3 years, depending on what you and your physician agreed on. So you put on the patient a speculum and then you rotate it so that you can see everywhere on the vaginal vault and the vagina itself. If there's a lesion that is suspicious, you biopsy. Remember that screening will tell you exactly what you knew. If this patient has had a cancer, it means she had a high grade. You will find it because it was there, it progressed to high grade before. Because HPV is a multifocal disease. If a patient who has had a HPV-related cancer will have a VAIN, vaginal intraepithelial neoplasia somewhere, will have a VIN, vulval intraepithelial neoplasia, and CIN. So if you are going to chase a pap smear, you are going to get abnormal cells which will know what to do with them at all. Put a speculum or do a PV. If the patient comes and says, I'm bleeding, yes, put a speculum biopsy. Not bleeding, put a speculum, do direct inspection. You can even put acetic acid if you want to, but you can see a lesion if it's there. The HPV vaccine is not contraindicated in women. It has been shown to have localized side effects, which is some heat a little bit. There was a small percentage of people who had an inflammation that persisted beyond 7 days. There's none that has been shown to have systemic disease associated with HPV. So it's also encouraged. You can take it when you are pregnant. But I think it will be one of those things that will be by the way, because pregnancy is a period of 9 months. You can still wait. So the other question is if there's a role in vaccinating a patient who's already exposed to HPV. So there's a yes and a no answer to that, Javlan. So the reasons being, the yes being, you can vaccinate because of what I showed you on that slide that had a phytogenic tree. So this phytogenic tree shows you that if this patient has an HPV 16, you can vaccinate them against the other ones that are there, this one. So you can vaccinate against the other ones because they share the same genetic material. So you can vaccinate. That's the part of a yes. The no component is because people are thinking about the finances. If you already have an HPV 16, so why should we give you a vaccine that covers for HPV 16? We are wasting money. We might have to treat 200,000 people to prevent one cancer, which that in economics is not cost effective. But if you are taking the vaccine yourself with your own money, and if the patient can take the vaccine themselves with their own money, you can tell them that if you are 1 in 200,000 people who have cancer, who could have benefited, you wouldn't want to. And because the vaccine is not that expensive, assuming that that expensive means that people can afford, yes, then you encourage them to go and take it. So that's why the answer is a yes or no. So, but I would move towards a yes and say, let's vaccinate everyone. They are busy with research to look into the therapeutic vaccines on HPV. We are not yet there. There's a vaccine that covers for 9 strains, because the one that we know, there's one that covers for 2 strains and the one that covers for 4 strains. So there's one that covers for 9 strains that is called the nano vaccine. So it's not yet here. Most people think we really don't need it. So if you are a lesbian, should you do a pap smear? The answer is yes. I'll tell you why. I've had a patient who came as a lesbian who had a gonorrhea. One had HPV related or abnormal pap smear. Because when you do the sexual activity and you are sharing the dildo or the as a lesbian, you are sharing the dildo or whatever the instrument that you are using. So you are transferring the whatever material that is in the vaginal cavity to the other, subsequently into the cervix. Unfortunately, human beings are not trustworthy. Even the lesbians, there are those who go and have sex with other men, and there are those who have had HPV. The unfortunate part is, if you are a lesbian now, it does not mean you don't have HPV. HPV, you can have it and it starts showing years later. Anybody who has an HPV now that we test today definitely didn't get it last year. So it's probably very old. So yes, even if you are a lesbian, you need to do the HPV test, because we know that the sexual practices have changed drastically so much these days. So the guidance on pap smear after hysterectomy, like I said, it's good to do, put a speculum, look. If there's a lesion that is suspicious, do a biopsy. A false smear is really not a good thing, especially on the patient that had a hysterectomy because we knew that they had that lesion. Put a speculum. If it's suspicious, you biopsy, because a pap smear will give you false alarms a lot of times. So somebody says they're not clear when to start a screening. So I was sending you to the guidelines from the um, South African HPV Advisory Board, which indicates that you can do them every 3 years, from 35 every 3 years, provided both HPV and cytology were negative. However, they had said that, so they even tell you how long you can do. So for how long you should stop. They say you can stop at 55 years. So the two that I've mentioned is on HIV positive patients. Whereas if you are HIV negative, you can do it every 5 years, provided the last pap smear and HPV were negative. You can do every 5 years, and you can even stop earlier. Whereas with HIV positive patients, you progress it a little bit more because they had an increased risk. However, the data that is used to extrapolate that was based on many countries not having access to HIV treatment, with our immune system being bad, viral loads being bad. Right now, we don't have newer studies that are proving, because we think that when you're on treatment, your immune system is reconstituted, that you are almost the same as a person who's HIV negative. But for now, let's use that part. The part that says if you are positive every 3 years, and then if it's negative, whatever, if it becomes abnormal, then you have to triage them to colposcopy. Then you are going to repeat after 6 months. And then if, because they were abnormal, they now exit that 3 years cycle. Now they now go to an annual cycle, because now you want to be on the cautious side. Even after you have done the LEDs, you want to be on the cautious side. So yeah, this is where somebody was talking about the annual pap smear. Yes, so you can do annual pap smear. I think even at the clinics now, they don't turn patients back if you come every year. 12 months is not such a, a bad time. So in case of advanced cervical cancer at first consultation in private practice, who do you refer the patient to? Gynaecologist or medical oncologist? So the best way, if you have a luxury of having a gynecologist around or within reach, please start with a gynecologist. This is the reason. A medical oncologist is likely going to give chemo, and there are those who do both, who will give chemo and radiation, which is good. But this could be the patient that could have benefited from surgery. We know that when you are comparing a little bit advanced stages, let's say 1B2, if you take 1B2 healthy patients, exactly the same copy, surgery versus radiation, we know that the cure rate is the same. However, the problem is the side effect profile. Side effects of radiation, which we can talk about this day, are higher and it results in some morbidity. So if this patient can benefit from being staged by the gynecologist, so they'll be going to see the gynecologist. If they are not operable, then they'll be sent back to the same team. So if, let's say, for example, you have a team that you work with, but that team is not the gynecologist, you can write in a referral letter. This patient is supposed to be referred to whoever. I'm sending the patient to you to stage for operability. If she's not operable, please send back. So they'll be able to stage this patient. And again, if you look into that stage, which I still think I should give you as a homework, it gives you an opportunity to stage clinically and radiologically, and pathological. So FIGO has expanded on the ways that you can use to stage. But yes, refer, if in doubt, to those guys so that they can give a proper staging for the patient and the patient gets the best treatment from the beginning. Is there a benefit of vaccinating patient after their sexual debut? I've answered this already, that even though you have gone through sexual debut, I showed you that 35 and 33 are the commonest in DRC. We're on 16, 18, 31, and 33. So if we give you a vaccine, it will protect you about from 35, 58, and the rest. So there's still that benefit that exists. So it's not 100% zero. It's just that we cannot use that argument to say to government, buy the vaccine for everybody, including those who have had sex already. We know that it won't give us the benefit. It goes back to that issue that I'm talking about. You might have to vaccinate 200,000 people to prevent one cancer, which again is not cost effective for a low middle income country. Unless that patient is buying for themselves, nobody should stop them. It makes a lot of sense. Can LEDs cause cervical incompetence? Yes. A properly well done LEDs, if you look into that picture that I showed you, it almost looks like a cone. The biggest complication of a LEDs is cervical stenosis. Because of the burning effect when you are doing a LEDs and when you are trying to cauterize to stop the bleeding, you are likely going to, that inflammation might occlude the os completely. So that's why after the LEDs, you take the same roller ball, you push it through so that the canal remain patent. But it can cause both of them, depending on how long the cervix was. Remember, the cervix has no growth plate. It will just heal. It does not recover back. So depending on how long it was, it might cause both things. It's a risk for both incompetence and stenosis. When I counsel my patient, I tell them about both of them, especially if they are still women of reproductive age who still desire fertility. So yes, condoms do reduce HPV, but condoms do not stop HPV. Yes, they will reduce. If we have to talk about mathematical formulas, if the condom was only halfway on the penis and on the glands on the last minute, it means that that vaginal mucosa would have been exposed for that last minute, not the entire period. So yes, they reduce, but they do not stop. Yes, you can use them to reduce, but we know they will not stop completely. I think there must be one on the charts. Okay.
Thank you, Dr. Mbodi. I think there was a question earlier on before I got disconnected, whether or not an asymptomatic carrier can actually transmit HPV to their partner.
Yes. So in actual fact, the reason most of of the people are now rushing and saying we must vaccinate men is because it's unlikely that men will have suffer from the HPV effect, except if there are men who have sex with men, because you'll have the same anal mucosa is the same as the vaginal and cervical mucosa. They'll have the anal cancer, and you can also have esophageal cancer. So yes, men usually on the penis, you'll never see anything unless you see the warts caused by the other low grade HPV subtypes. But when it comes to high grade, yes, they will spread it. So hence, if you have to, please use that condom, reduce the risk. We know it won't be completely gone, but get the HPV vaccine for your daughters. If you have money for yourself, get HPV vaccine for yourself. So, but if you can't because it's way beyond and it's late, please make sure that your patients are screened. And when they screen, treat them. If the patient has a high grade lesion, treat them. I see there's a hand from Sanjay.
Yes, there's three hands. I'm not sure if they were raised by chance. So let me just check quickly. Sanjay, would you like to unmute and maybe make your comment? I think the hand went down. Okay, Dr. Mukhumuzi, would you like to ask your question or make a comment? Or lower your hand if it was by chance? You may unmute. All right. Esther, is your hand up by chance?
Okay.
Anyway,
when
Doc,
people are when people are still thinking, there's a question about when to start giving the vaccine.
Yes.
Yeah, we say the target is before sexual debut. Evidence, everybody who has done a study here in the country that has to do involve sexual debut will tell you people are having sex at around 13.5 years. So 13 and a half years. So if that's the case, it makes sense. That's why government has introduced that you must get it at 9 years upwards. So before sexual debut, if you can prove that there's not sexual debut, you can give it anywhere. The vaccine is not age dependent per se. So 9 years is taken because it's closer. Again, we don't give it at birth because we know that by the time they are 9 years, we are not sure about that immune activation, how long it will last. It is not yet known, but we know it's decades, but we don't know how long. So the closer to sexual debut we can buy, the better, because it almost guarantee that the immune system will still be active and protected.
Yes, thank you very much, Doc. I just wanted Dr. Pakati to say hi to you. I'm sure you guys work together very closely. Dr. Witubelo, sorry to put you on spot. Would you like to say hi and maybe just give Dr. Mbodi some quick feedback? Thanks.
Oh, wow. Thank you, Dr. Lesoro. Good afternoon, colleagues. Thank you, Dr. Mbodi, for the great talk. We're really proud of you. Keep up the great work.
Thank you, Dr. Witubelo. Yes, I think there's more questions. I think most questions are around the vaccine. It seems like Dr. Mbodi, you would need to come back and maybe just focus on the vaccines. I see there's a question around the number of doses, when would be your cutoff time? Any time, is it any age, or do we have a specific age group that we should be giving the vaccine? I'm not sure if you have a quick answer to that. And
Yep.
then we can be summarizing the night. Thanks.
Okay. So regarding the dose, we were giving 2 doses of either type, whether it's Cervix or Gardasil, 2 doses, because there's evidence again in the countries that have done research well that instead of giving 3 that were given, their findings of that research says 2 doses are not inferior to 3. So they don't say they're the same, but they're saying they are not inferior. So in a country like ours where we need money, 2 doses have been seen that they do the same function. They do the same coverage. So give 2 doses. Cutoff point. So we are supposed to say from 13 until sexual debut. But if you have to increase it and say, no, man, these patients can take. So there's a cutoff of between 45 and 55, depending on which country you are in. So you'll say the safest is 45. Anybody after 45, you are less likely to benefit from any vaccine, whether it's before sexual debut or after, you just want to protect yourself against the other parts. So 45 cut off, but two doses, we know they do wonders. Take the 2 doses.
Yes, great stuff. Just from my side, the issue of colposcopies that are all over the country in most district hospitals, including here in Mpumalanga, it's something that I know for sure. I just wanted to get your advice around how we get to use those colposcopies, because they are there, they are lying dormant. It seems like there's a skill issue, or the service is still deemed a service that should be provided by very skilled gynecologists. So I'm not sure what programs are available for particularly for medical officers to be trained so that those services can be available in district and rural healthcare. Thanks, Doc.
So when we went and met with the Bill Gates Foundation, and we were informed that they've donated to the Department of Health a lot of equipment, we volunteered and said we are ready to train. It was not only us in vets, but guys in Pretoria, guys in Medunsa or Sifako Makatu. So I'm talking about the Gauteng group only. So I think the same thing could be there, that there have been people who have been agreed to train. Training to do a LEDS is quick. Training for a colposcopy is difficult. So if we are going to train people who are going to do VIA and VILI, we can train them over the weekend. I think, let me put a challenge to you, Lisiho and Billy, and say, I'm available to train these people voluntarily. So no stipend, no petrol, no food, nothing. Voluntarily. So if this platform can organize, because we'll need a talk and then have a hands-on training. I can organize so that we can have a talk on selected medical officers from Mpumalanga or whatever region. We have a talk on doing LEDS, colposcopy and LEDS, or just LEDS. Then we'll do a hands-on with an equipment wherever they are. We'll do an outreach. Me and my team are ready. We'll come to them, teach them how to do LEDS, and they can continue from there.
Okay. No, I'm happy with that positive, proactive action. So yes, I think we will be in touch, and I think most medical officers who are here are likely to be very interested. So let's work together. So we will have those follow-up conversations and see how best we start, even just basic pap smears for primary healthcare to improve the quality of these screening tests. These are some of the things that I think we need to work together and collaborate on. Dr. Magagula, can I hand over back to you as we close this session, just to summarize and close? Then I will just do the way forward. Thanks.
Okay. Thanks, Lisego. Thanks, Langanani. We really appreciate, all the insight and knowledge that you have shared with us. There's so many questions, and I think some of them will be addressed, outside the webinar. Otherwise, we'll keep going until 2100 hours or beyond. But we'd like to appreciate Dr. Mbodi and all the participants that have made time. It was a very informative session, and indeed we accept the challenge to train colleagues that need the skill out there who are not trained on colposcopy and LEDS, and they will definitely be in touch. Dr. Mbodi, we appreciate all the effort, all the positive energy that you've brought tonight. So yeah, everyone have a good evening. Thanks. Back to you, Lisego.
Yes. So just before we close, colleagues, I just want to share some quick updates with you. Just remember that if you are a member, you will get your CPD points and certificates. You need to attend for at least 60 minutes. If you are a registered practitioner with the HPCSA, there's no need for you to submit your certificates. We submit on your behalf. I want to talk about the next seminar, which will be on the 7th of March. We are looking at the obstetric side, and which is preeclampsia, focusing on risk stratification, how to manage patients antenatally during delivery, and also the postnatal care. We have Dr. Valerie Vanevel, who's also a specialist obstetrician, and we hope that this will be an exciting event. On Thursday this week, we have the HIV masterclasses, and we'll be looking at respiratory conditions that present in HIV. And I hope that those who are writing the diplomas and just wanting to enhance your knowledge as well, you will be attending this session. For seminars in surgery, on the 1st of March, we are looking at pediatric abdominal emergencies, and we have Dr. Marisa de Villas, and I think there's going to be a lot, and Dr. Machete, who's going to be our convener for that session. I hope that you are happy with this. Just to remind you for the last time, support the platform. We want to bring colposcopy training to you. So let's try and make it work. And yeah, and just to thank you again, Dr. Mbodi, you have made a very big and something that seems a little bit complex sometimes, but you have made it very simple. And I think we have grasped, so much from your talk. I also got a lot of energy and that passion you have for women's health, particularly around preventable malignancies and death. So thank you very much. It's all appreciated. Dr. Magagula, thank you very much for being a friend to the platform and continuing to spearhead these particular sessions. To everyone who's attending, please enjoy your evening, and may the good Lord richly bless you. Thank you.
Bye.
Bye.
Bye-bye.
Thank you, Doc.